Good day, my dear postgraduate students. Welcome to Trap for R.A.T.S. Topics and recent advances for postgraduates. And R.A.T.S, we all know, racing against time for students in pathology. The topic that I had chosen for the day is From Recent Advances 24 by Sebastian Lucas. And it is titled as Role of Autopsy in Sepsis and the related fatal syndromes. Sometimes there can be other questions that can be asked for us, which are enclosed in the enclosure. Also, all along, I'll be quoting a good number of references, which, if you people feel, can go. Think of the subheadings. The subheadings will take you to the answer. A question like this is very vague and it has got no boundaries. At the same time, if we have got a compiled set of headings, we will be able to answer it better. With that in mind, I have processed a list of headings which are found in the text. Most of these are familiar to us and they are seen elsewhere. So let us go to the topic straight. The definition of sepsis, like pornography, was in the minds of the beholder. I don't know what it means, but probably there is so much of variability that it changed from person to person, and whoever saw it has assumed a meaning like that. That might be one of the definitions. There are a lot of difficulties or major problems in this sepsis. One, imprecision of case definitions. Two, there is a subjective variation from person to person. At least to my knowledge, three people are involved in this study. One is a clinician, two, a microbiologist, obviously, and three, a pathologist. And when the panel changes, the ideas change. Vital organ dysfunction. And in UK, it is a major cost for health. So these are some of the problems that are being faced. Is it not out of context? UK, it is a major cause of health. Not so, because it takes so much of money, manpower, time, and material to study this topic that it has found a lot of hindrance even in countries like UK, for which we should have an order of the coroner or the fiscal. Fiscal is a person, a government official who gives the directions. I hope these things are in mind and it falls in suit with the series of autopsy topics that I am dealing with. Now, what is the role of autopsy in sepsis? It can be to assess the presence and the cause of sepsis. One, very important. You people will have to by heart this. Two, to consider an alternate diagnosis. All that appears as sepsis need not be so, or it can be a secondary infection. So what is the alternate diagnosis? Three, treatment would have been given. What was the response to the treatment? And four, it does provide a ground for research into the pathogenesis of sepsis. In that way, autopsy plays an important role in sepsis. We will have to justify the topic thus. And I would like you people to kindly go to this particular reference. One, it might throw a lot of light from which I had picked up a leaf or two. And the role of autopsy in sepsis, I had mentioned earlier, it is a repetition. So I'll go to the next slide. What is sepsis now? There are different words. There is sepsis, there is septicemia, there is complicated sepsis, there is organ damage, so on and so forth. So we will have to identify exactly what it is and treat it. Documentation of infection with the systemic manifestation of sepsis. So this is a second one. What are the manifestations of the sepsis? Third one, is there a complication such as a septic shock or a hypotension? And finally, from the feedback, is the diagnosis of sepsis confirmed and what are its changes? This is more or less a repetition of the previous one, but then it is from the pathologist's point of view. Unfortunately, most of the patients from the ICU who have been declared dead due to sepsis do not fit into it. There will be other systemic manifestations and disorders which would have had superadded infections and thus diagnosed as sepsis. Again, the question, what is sepsis? It is the presence of infection with organ changes. So there is systemic manifestation. It can be severe, in which case it is called severe sepsis, which is sepsis plus organ dysfunction plus organ damage. Normally, bacteremia, etc., we do not find the changes as such. So when these are found, it comes into the fold of severe sepsis. SARS, systematic inflammatory response syndrome. This I shall be touching upon. Then the autopsy feedback helps you to accurately redefine the cause. That is why always you have got a provisional cause and then the final diagnosis. Look at this word, for instance, a peritoneal sepsis. What do I mean by it? Look at this. The peritoneum is opened and then it is a world of pus. We should thank God if it is restricted to one organism. A peritoneal sepsis, to give you an idea. This is an important picture. I would like you to kindly follow the flow diagram as such. There can be some important causes like this. For example, it can be a meningitis, endocarditis, pyelonephritis, cholecystitis, osteomyelitis, and so on, which can lead to an indirect lung injury. Or there can be a direct infection of the lung. Also, you find that there are the various mediators which are released into the circulation. And there can be the mediators that come from the airspace also. And these are certain substances which are being liberated. What is PAM? What is DAM? What are the pathogens? And what are the cytokines of the various mediators? All of this ultimately can lead to a loss of the alveolar capillary integrity. In the text, actually, he says that there can be a loss of the endothelial cells. There can be a widening of the interendothelial junction, or there can be a loss of the basement membrane, all of which can be leading to the release of the mediators, the accumulation in the interstitial space, or there can be an extravasation. This is almost an exact replica of the chapter on inflammation that we have read in Province. So kindly go through it. It is just to give you people an idea. If you are not convinced enough, these are some autopsy pictures. One is from the skin, a case of a meningococcal septicemia only, in which there is a marked edema, massive edema, and there is the widening of the capillaries and extravasation of the RBCs, and it is flooded with the bacteria. Also, I find that there can be an acute glomerulonephritis and a pyelonephritis. These are all the neutrophils and areas of necrosis that could be seen in another case. So there is a role for the pathologist in sepsis. That is what he says. One is a clinical diagnosis. Two, definitely a microbiological diagnosis. And three, the pathologist will not be able to do much without having a histological proof for himself. And this is what I said. These terminologies, I would like you people to kindly back up. It is a little difficult, and even I picked them up at the last minute. But it is worth its weight in gold. TLR, toll-like receptor. PRR, pattern recognizing receptor. NLR, neutrophil to lymphocyte ratio. PAM, pathogen associated with molecular pathology, and DAM, damage associated molecular pattern. So these are things that we people should be knowing. And this is my third reference over here. I would like you people to go to the molecular patterns and receptors if you would like to study further. This particular diagram, you and I and your friends shall all draw. So there is an infection, there is the release of the PAMs, there is a tissue damage, there is a release of the DAMs also, which lead to the PRRs, and then all the abbreviation that we had mentioned over here. For example, neutrophil lymphocyte ratio, etc. All this can lead to an innate immunity, or they can result in the manifestation of SARS and the other symptoms. Whereas it can also happen because of injury. This particular concept is very important. It is not always due to infection. It can be because of injuries also, which will again be shown by a series of pictures. An injury, there is the dams that are being released, PAMs are released, and similar receptors are being activated, and finally the manifestation. This one you people shall and will buy. Look at this picture. It justifies what I have said. Again taken from the net. That can be an infection, and there can be a manifestation of a sepsis. It can result in SARS. What is SARS? Systematic inflammatory response to sepsis. Also, you find that these can happen in a number of other conditions, such as trauma, surgery, burns, pancreatitis, and so on. That is why it has been mentioned earlier, all that appears as sepsis is not sepsis. This is a fantastic, what to say, a wheel-like appearance that sets into motion. So at one point you find that there can be a lot of overlap. Infective and the non-infective causes for SARS. So here is the non-infectious and the infectious cause to the series of events. They can lead to SARS, systematic inflammatory response syndrome, and MODS, multi-organ dysfunction syndrome, which can result in death. Also, infection can lead to sepsis or a severe sepsis, which lead to MODS and finally a death. In this picture, I find that there is a lot of overlap of the circles over there, and then there is a convergence. Ultimately, it results in MODS. These diagrams you people can draw so that it reinforces your answer. This is somewhat analogous to your COPD, chronic obstructive pulmonary disease, in which you have got a bronchitis, and then you have got a bronchial asthma, you have got a bronchiectasis, etc., or even an emphysema. You find that there is an overlap. Ultimately, there is a point of convergence. So I would like you people to kindly read it. This diagram is even more simple. in this point, I find that there is a convergence of SARS-DAC. There can be a disseminated intravascular coagulation and MOTS, or there can be a TTC, thrombotic thrombocytopenic purpura. So the relationship is even more colorful over here, taken from Bone et al. I would like you people to kindly appreciate. Now, SARS, I told you, can be a question. What are the various causes? It can be divided into infectious causes and non-infectious causes. Please remember it like this. And when we say infection, it can be viral, bacterial, fungal, or parasitic. Whatever names you can recollect, you can mention those. It can be Epstein-Barr virus or a HIV, streptococcus or a meningococcus, mycobacterium tuberculosis, aspergillosis, and falciparum leishmaniasis. I'll be showing a picture of it. And also meningococci. Also, these we have mentioned earlier. So, what are all the various infectious and the non-infectious causes, and what are the viral, bacterial, fungal, and parasitic causes for infection? This is taken from the article in Recent Advance 24. This is another picture that I picked up from the net called as acute melioidosis pneumonia. Now look at the massive pneumonia over here. It almost looks like a malignancy, but then there are patchy areas of bronchopneumonia seen throughout, and there is a culture. And this is also seen in the form of a pustule in the skin. So there can be multiple lung abscess in this case, supposed to be fatal. And this is again important from the laboratory point of view or from the autopsy point of view. What are the microbiological and immunological samplings that we will have to do at autopsy? Remember my earlier class, all the samplings will have to be done as the first step, even before the cadaver is put in formalin. So this can be a blood for culture, a PCR, blood and the serum for serology, urine again for diseases such as Legionella, organ tissue for the culture, etc. Bacteria, fungi, and mycobacteria. Feces again. It can be, for example, typhoid, CSF, meningococci, any other tissue. Cytology preparation. Okay. And what are all the other practical notes that you people should be having? You will have to rule out HIV, for example, and what are other molecular diagnoses for which we can prepare a formalin and a paraffin embedded section, and any other special stain that is required. So what to look for means you'll have to look for all this material for making a diagnosis. Sometimes the complications arise after survival. After survival in the census, there is a septicemia and the patient survives. But then there can be residual lesions. That is what is the meaning of this. So there is persistent critical illness after survival. Now what are they? There can be neurocognitive dysfunction. There can be cardiorespiratory failure, renal failure. Sometimes there can be a gangrene and an amputation, neuropathy, myopathy, and there can be an immune dysfunction also. So all these are important. For example, there can be the development of a malignancy. And what can be the outcome of a sepsis? It can be death, it can be persistent critical illness. That is what is this? And the recent survival from sepsis can lead to any of these complications. And what are the risk factors for sepsis? The risk factors will be, say, it can be malignancy, diabetes, alcohol, autoimmune disorders, extremes of age, and obesity. These are all the general risk factors. There can be specific risk factors such as hyposplenism, splenectomy, a sickle cell disease, congenital cirrhosis, HIV, and so on. So these are again a list of risk factors which you people can go through. This is another one. So there is the meningococci. So this is how it appears. It is a diplococcus. Diplo means two. And this is the appearance of it. This is how it will be appearing. It is a gram-negative bacteria. And this is a neutrophil having pairs of these organisms. in a diplococcal infection. CSF might be useful, or sometimes the sputum as a source for diagnosis. The credit to these pictures goes to the author below. Also, at autopsy, when we do open up the organ, sometimes there is a turquoise-like discoloration. So there is a brain over here, there is a heart, and then there is a ventricle over here, sometimes the perforated scrotal skin. All of them show some kind of a hemorrhage and a greenish or a turquoise discoloration. So this was mentioned in an autopsy article, secondary to treatment of septic shock. The authors are below. Now look at this picture over here. I am finding a lot of these histiocytes. The histiocytes are large cells. They have got a pale cytoplasm. Nucleus can be vesicular, slightly eccentric. Sometimes there can be multiple nuclei also. But what is strange is within this we will be finding other elements such as the normoblast or sometimes lymphocytes, neutrophils, and so on. So this is called as lymphohistiocytosis or a hemophagocytosis. This is extremely important in finding certain other diseases. I'll give you one classical example, the typhoid. You find that there is an enlargement of the Peyer's patches. When you study the Peyer's patches, you will not be finding the organism, but instead there will be the histiocytes, and then there will be the destruction of the RBCs, there will be erythrophagocytosis, which is the classical histological hallmark of typhoid other than agranuloma. So there are a number of conditions where this hemophagocytosis or lymphohistiocytosis could be seen. I would like you people to again go through the list. Typhoid is my favorite one. Probably you people would have come across these in infections, in lymphoma, myelodysplastic syndrome, autoimmune disorders such as SLE and juvenile arthritis, and so on. So kindly mention this as part of an answer if you people get this as a question. And hats off to this gentleman over here. Again, the reference is given. I would like you people to kindly go. So in this case, I find that there is an obvious coloration. So there is this, and then there is a special hematoxylin that has been done, which imparts a brownish color to this. There is the hemophagocytosis, and almost like satellites, they are found within the engulfed cell. This is yet another condition wherein there are vacuoles and also the engulfed cells within the histiocytes. So hemophagocytosis, again, if you get this as a question, what are we supposed to write? These are the groups of disorders and these are the lesions. The groups of disorders will be neoplasms, autoimmune diseases, transplantation, other diseases, and unknown causes. So this will be one, in which you'll be finding the various lymphomata. There can be the SLE, rheumatoid arthritis, so on. There can be transplantation of the organs. Then hematological disorders such as sickle cell anemia, and strangely in bypass surgery and so on, hemodialysis, pancreatitis. These are all very intriguing diseases wherein the pathologist will be struggling to have a finding. And obviously, whenever you get a question, write unknown or idiopathic, you will be correct. So this is again a favorite picture of mine, not because I'm an expert at it, but I got it as a university exam slide. So this is a large cell, a histiocyte or a monocyte. I find there is a reniform nucleus, there is a nucleolus over here, but then there are vacuoles within the cytoplasm. And what I am seeing is, I am seeing a dot and a dash. So look at this one over here. There is a dot and a dash that is seen. So this is classical of leishmaniasis, Kala-Azar. So it is a parasitic disorder. You will not go into the details of it. There can be a massosplenomegaly in the patient, but in the bone marrow and the other lymphoreticular organs, you will be finding a dot and dash inclusion. Sometimes they will be rupturing and spreading to the other cells. So this is classical of Kala-Azar, which is more common in Africa. exam slide. Remember dot and dash. Again, I repeat, there is a dash and then there is a dot. You find that there is a dash and then a dot. Coming to this one again, go back to the first chapter of inflammation. You will be having the various products. Also, it will be given in the topic on septic shock. So there will be the various microbial products and it will be activating a lot of this inflammatory system, such as the Hedgeman factor or the complements or the endothelial factors. And the interleukins are released thereon. Also, you will be finding some anti-inflammatory substances being produced simultaneously. So you will have to mention this particular series or at least have an idea. So there can be under coagulation also you have got all this. The pro-coagulation and the anti-coagulation. There can be microvascular thrombosis which cannot lead to multi-organ failure. So why do you get a multi-organ failure in a case of a septic shock? Septic shock itself is a question for us and you find that the features will be totally different from the classical shock. So this again are the steps in a case of a classical shock. You find septic shock will be different from it. As I told you earlier, there can be some conditions which are simulating sepsis. All that appears as sepsis is not sepsis. So that is why you find that specific sepsis diagnosis can be missed or sometimes overdiagnosed. Because they can be having non-specific clinical features and anybody who is admitted to the ICU can be having these manifestations. Diagnostic samples are not being taken immediately. What will happen when a patient is going to be admitted to the ICU? Immediately everybody will pounce and try to revive and save the patient. So the delicate method of sampling and then sending it for the correct investigation, etc. will be overlooked. They will be more interested in correcting the electrolyte imbalance, maintaining the blood pressure, and so on, preventing the convulsions. So you find that more attention is given to saving than identifying the disease as such. It is only in a case of intensive care unit wherein there is a separate wing for infectious diseases that the autopsy can be reviewed and then divulge of this. So there is a systematic procedure. The autopsy is done. It gives a feedback for the diagnosis. And what are the other simulators? It can be a cytokine storm. It can be hemophagocytosis. SARS, I have mentioned the other diseases, autoimmune diseases such as the rheumatoid arthritis or SLE and adult onset Still's disease. And combining anecdotal post-biopsy wisdom with the clinical and laboratory findings will be of paramount importance in coming to a conclusion. Combining anecdotal post-biopsy wisdom with clinical and laboratory findings. A beautiful compilation of mine. And this is the adult onset Still's disease, wherein a patient presents with severe arthritis and there is a daily spike in the fever, a salmon-colored transient rash of the skin. Last but not the least will be the classical Waterhouse-Friderichsen syndrome. To my knowledge, the best example will be meningococcal septicemia, wherein the patient dies of shock and at an autopsy you find that there is a necrosis, hemorrhagic necrosis of the adrenals, and there will be the hemorrhage elsewhere in the body also. It is the best example for disseminated intravascular coagulation. So there is a clotting that is happening in multiple parts. At the same time, there is bleeding elsewhere that goes on. These are all classical examples of patient is no more after the successful surgery. Operation success, patient died. Mercy. I hope you people have recollected the various importances. I would like you people to kindly, leisurely go through the tabular columns and elaborate the abbreviations and pick up as many questions as possible from today's discussion. Thank you.